I'm Jacqueline Pelfy with Sanford Health News. We are here today with Dr. Sam Milanovich to talk a little bit about pediatric cancer and research in personalized medicine. Welcome.
Thanks, Jacqueline.
Thanks for coming here today. First of all, tell me a little bit about where you're from and how you got into who decides they want to be a cancer doctor.
Well, I'm a pediatric cancer doctor and a cancer researcher here at Sanford Health. So my interest is in both taking care of children and young people with cancer, but also studying the causes of cancer and how can we learn more about what causes cancer and why it responds to treatments.
Did you start out wanting to work with children or wanting to work with cancer? Which came first?
I had a little bit of both. I think like so many of us, cancer touches our lives in different ways. And so, as a science major and a young medical student, I was curious about the biology or the causes of cancer, what makes it, happen and behave the way it does. And that kind of coupled with, as I started getting into clinical medicine, just I enjoyed the challenges and rewards of working with children, because you're also working with families in that case. And so that sort of spoke to me and was kind of my calling, was to help kids.
I've heard you say before that working with kids is so different because they just kind of roll with things differently than adults.
Yeah, kids are amazing. We can learn a lot from kids. They will, maybe sometimes they just accept things a little more at face value.
Less jaded than the rest.
Sometimes, perhaps, yes. But kids also really understand things a lot more than I think we often give them credit to. And sometimes just listening to what a young person is trying to tell you, you can learn a lot.
Well, I think that knowing that you have to explain all of your work to very young folks will be helpful for me today. So I'll be able to hopefully understand as much as they do.
Well, Jackie, that children have their minds are more geared towards learning. So sometimes that might be easier.
I better put my mind in a different gear today. Tell me a little bit. We've done a lot of these podcasts where we talk about personalized medicine, that seems to be what everyone is calling it now. We've kind of given that a different name over the years, trying to find the right fit. But how do you define that in your work?
So, when I hear about personalized medicine, and this kind of became more of a hot topic or, a topic of discussion over the last several years, it kind of hit me as that's what we've been doing for even longer in pediatric oncology, at least. And so, To me, that means learning as much as we can about the biology of a patient's tumor or their cancer, and understanding, how that's driving that tumor, and then how can we use that information to better tailor the treatment for the child. So we use a combination of the child's DNA and how they respond to treatment to really, dial in what we think is the best treatment possible, rather than sort of a one-size-fits-all approach to treatment.
And what does that look like? I mean, does that mean that you figure out the right thing faster, or does it reduce your trial and error? Like, what does that really look like on the ground?
I mean, we really do it through clinical trials. So we've ran generations of clinical trials over decades, and what's an important part of what we've learned is that when we do those clinical trials, we collect as much information as we can from patient's cancer. So the DNA of their cancer, which is different than their own DNA, right? So a tumor, a cancer has, by definition, is going to have mutations. And we can find patterns of mutations in different tumors. And so what we do now is when someone's diagnosed with cancer, say leukemia, which is the most common, it's blood cancer. Mm-hmm. It's the most common cancer we deal with in children. We run a series of tests to find any combination of mutations. And we combine that with how the patient responds to the initial couple weeks of treatment. And then based on that, we assign specific treatment regimens based on that, including sometimes adding specific drugs that directly align to or match up with a specific DNA mutation that we found in the tumor. And we hope to through future studies, find more and more of those kind of direct matches.
That seems kind of crazy, right? That you can find this specific thing that might work and different, even maybe than from when you started, right? Are there more
right, yeah.
options?
It's continually evolving, and one of the challenges is as genomic technology and science is advancing, and we can understand and using computational biology understand the complex interactions. It is a challenge to take all that complex science and convert it into meaningful information for patient treatment.
So you do a fair amount of. How is your time split between research and practice? Is that the right word for it?
So I mean, yeah, clinical or patient care and research. As a physician who also does research, it kind of intertwines a lot. But my breakdown's about 50-50. And it never really feels, I don't know where one stops and the next starts, right? And which is part of the enjoyable part of my job is, we're learning about research, we're conducting clinical trials, which is research, but through that research, we're also doing patient care, finding the best clinical trial for the right patient. So it's hard for me to say that there's a hard line there. But
do you, how many clinical trials do we have? Do you know right now that are involve some of your patients or the work that you're doing?
We have several clinical trials. I did not pull the list.
That's okay. I know we have over 300 in general.
Yeah.
We have a ton.
Yeah, I can tell you that per percentage of patients, so pediatric cancer is much more rare than adult cancers. We have a very high relative percentage of clinical trials. So we in pediatric oncology are able to enroll our patients on clinical trials. We have even just some sort of simple registries, right, where we can collect tumor samples and collect information. So we might not have a trial where we're testing a new drug or combination of drugs, but we have those kind of trials where we can at least learn more about the DNA of your tumor and how you responded to standard treatments. And we have that open and available for every single patient that we take care of.
I always like to remind folks when we do these that you're under no obligation to be on a clinical trial, and that you still get the same standard of care if you're involved in one. It's not that you get less care, you just get that care plus some, and that you can choose to not be involved in it at any point, right?
Correct.
Sort of the patient bill of rights about that.
Yeah, absolutely. It's always up to the patient, or in this case, the patient and their families, whether or not they want to conduct clinical trials. As pediatric oncologists, we do lots of clinical trials, and first and foremost, we always are about giving our patients what's the best option. And so there are often times where I'll say, we have a clinical trial that, while technically you may be eligible for it, in our judgment, based on everything we know, we don't think that that's the best treatment option for you.
Sure.
So sometimes that comes from us as providers saying, yeah, there are clinical trials, but we think there's a standard of care that is very good, and you should do that. But the flip side is
it's
also
not a
true.
hard sell on clinical trials.
So many people are interested in clinical trials. Some people are not. They're not, they're not comfortable with the concept or that particular clinical trial, and that does not at all impact the quality of care that we deliver.
Talk to me a little bit about some of the research that you're working on. What's exciting about it in a level that I can understand?
I think there's we work on research on different levels. I think some of the exciting things that we do is, one, we're part of a couple groups of children's hospitals. So we have an international collaboration called the Children's Oncology Group, and that's really exciting because through that we're able to open trials across the country, and we partner with Europe, and we can really design some pretty innovative, detailed clinical trials to really start to get down to some of these to start to answer questions about treatment for different kinds of tumors. So,
what are the questions you're asking?
So it's just, for some of our tumors, we have pretty high success rates. So meaning we treat your cancer. So for instance, childhood leukemia, some of the common subtypes, we have more than 90% long-term survival. 95, and one of our last clinical trials we had a subset that had a 99% survival. So, but in those cases, we're left with a lot of toxicity, and this circles back to personalized medicine. So we can treat the leukemia and make it so it never comes back, and So many of our patients go on to live, pretty happy, healthy lives, but not as healthy as they could be. So our chemotherapy right now causes lots of complications, heart disease, lung disease, problems with the ability to have children later in life, some cognitive effects. So, it's one thing to at least treat the cancer, but then we're left with a lot of sort of collateral damage from the treatment.
Mm-hmm.
So we are designing trials to help, be more precise in our treatment and hopefully limit some of those long-term or
what does
late
that
effects.
mean to be more precise?
So that is learning as much from our previous clinical trials and then about the individuals we're taking care of. So what is your exact tumor DNA, and how does that tell us which therapies it's going to respond to or not?
So you may remove some of the things that you would, if you're doing
Exactly.
like a blanket treatment, maybe you take some of it out.
Exactly. So if you show us signs of being a very high responder, we can take away some of the more toxic chemotherapies. Sometimes we incorporate pharmacogenomics. So we do some genetic testing to see how you metabolize drugs, and then that can help us start at a different dose and thereby reduce some of the side effects we may cause.
And we talk about that a lot on these podcasts, just about how time-saving that is for people to sort of feel better faster with, not specifically in cancer, but in different areas.
It's a little different in cancer, but the same thing. If we have a treatment that if you metabolize it slowly causes side effects, it then needs you to take, one, feel sick from those side effects, and two, we have to pause your treatment. That's not optimal for your treatment. If we can predict how you're going to metabolize that drug and get you the right dose to get in that spot where we're maximizing treatment while minimizing reduce the side effects, that's beneficial to the patients.
How does it feel, seeing that now compared to when you started, to know that, which wasn't that long ago, it was a little while ago, we'll have this conversation again in 10 years, right?
Okay, yeah.
But to know that you're able to maybe not cause some of that collateral damage. Yeah, as a provider.
Yeah, as I look back, and that all comes from clinical research and the trials we've been able to do and how we combine clinical trials with the biology that correlates with it to help understand. Our trials are a lot more sophisticated. We use a lot more the genetics of a patient's tumor to be more specific with the treatment. And our treatment, arms are a little bit more complicated than they used to be, but I think that is to the benefit of our patients.
And then it probably feels good, like maybe someone's not going to have some of the issues, as many of the issues, or to such extent later because of treating their cancer.
Yeah, exactly. I mean, to see, some of the, the strides we've made and that we are continuing to improve our rates of long-term remission, essentially cures, and do that with a little bit less side effects is very rewarding. You also appreciate that it's incremental. It's step by step to get there, and that's kind of how clinical research works.
Well, I think that I have a little bit of a better understanding
Okay.
today. So thank you so much for coming on today, and we'll talk again soon.
All right. Thanks, Jacqueline. My pleasure.